might have seen the cathedral that was in rumbles after the Second World War, and they have been stone by stone rebuilding this fantastic cathedral. The people from Dresden can make miracles, so I'm very curious what the lady coming from Dresden standing here, what kind of miracles you're going to tell us about.
Good morning, ladies and gentlemen, dear chairman. I'm not a miracle, I'm Linda Schmiedel from Dresden, and I want to talk about a procedure which is called renal denervation if the PC is working. I have no picture here.
Press escape.
Thank you very much.
Always press escape.
In case of emergency, if a woman works on the computer. Okay, so what I want to talk about is the risk to fail in a renal denervation because of the unfavorable role of accessory renal arteries. We know that arterial hypertension is a common disease in industrialized countries and often appears in obese patients. Up to 15% of these patients suffer from a form which is called resistant arterial hypertension. This means that we have a failure to reach blood pressure levels below 140 to 90 millimeters of mercury in patients who are adhering to an appropriate 3-drug regimen, including diuretics. Furthermore, for the diagnosis of a true resistance, you have to exclude secondary causes such as pulmonary diseases, endocrinologic diseases, sleep-related disorders, as well as reversible hypertension causes. The point is that we have the data from the Framingham heart study, which was published in 2002. And these data showed us that there's a strict correlation between the blood pressure level and the risk for the development of cardiovascular diseases. The data said us that with each increment of plus from 20 to 10 millimeters of mercury, we get a risk duplication for the development of stroke, myocardial infarction, as well as chronic heart failure. So our aim is to treat these patients, especially those with a resistant hypertension form, sufficiently. If we fail in the known treatments such as sodium restriction, weight loss, physical activity, as well as in drug treatment, we've got one more option left, and this option is called renal denervation. On the top of this slide, you can see 4 pictures as a scheme of this procedure. With the leading catheter system, you get access with a special ablation catheter here in this slide, the Simplicity catheter system, into the renal artery. And what you do is the following. You put the tip of the catheter, in which is the ablation electrode located, to the artery wall, and then start with your ablation. After about 2 minutes, you put this catheter 5 millimeters back and rotate it about 45 degrees. Then you can start with your second ablation point. At the end of the procedure, in each renal artery, you will have a helical line of ablation points that destroy the sympathetic nerves, which are located, as you can see here, in the adventitia as well as in the media and the intima of the renal artery. The thesis of this procedure is that patients with a resistant hypertension form have an overactivity in this nerve system. So if we destroy these nerve information ways, we will have a blood pressure lowering effect. And that this works has been shown in several studies. The biggest ones were the Simplicity HCN1 and 2 trials, and here, for example, there are the results for the HCN1 trial. Just remember, we have got patients who are at the end of their treatment options. If you perform renal denervation, this study has shown that you can reach a blood pressure lowering effect of about minus 33 to minus 19 millimeters of mercury. My problem was the limitation to all of the former studies. All of these studies have been performed in normal renal arteries, as you can see on this slide. What we saw in our screening was that many of the patients with a resistant hypertension form have got abnormal renal arteries. Here you can see a 3D MRI reconstruction. On the left side, this is a normal renal artery with a length of more than 20 millimeters and a diameter of more than 4 millimeters. On the right side, you can see the renal arteries we saw in our screening program, such as concomitant main branches or pole arteries. So what we asked ourselves in this situation was if we maybe deny patients with resistant hypertension and accessory renal arteries an effective treatment. So what we wanted to answer was, is the absence of radiofrequency ablation in accessory renal arteries a predictor for the ablation success? What we did was the following. Patients who underwent renal denervation got into a follow-up period of about 6 months. 66 of the initial 110 patients completed this follow-up period, where we performed a 24-hour ambulatory blood pressure measurement as well as an office blood pressure measurement. In the first step, we wanted to take a comparison between the blood pressure after 6 months to the baseline. And in the second step, we took the correlation between blood pressure changes and the completeness of ablation. What we saw was that at least 63.6% of patients responded to the procedure, and this was defined as a blood pressure decrease of more than minus 10 millimeters of mercury. Nearly same results we got from the 24-hour ambulatory blood pressure measurement. So in these figures you can see on the bottom of this slide, it's much more obvious how the differences were between responding and non-responding patients. We had about 1/3 of patients who was not responding to the renal denervation procedure. And under a stable medication, they had even an incline in blood pressure, here systolic office blood pressure, of about plus 14 millimeters of mercury. In contrast to that, those who responded to the procedure, here you can see on the right side in the scheme, had a significant blood pressure decrease of about minus 20 millimeters of mercury. The second step, we wanted to take a look about the completeness of the ablation. As you can see in a table on top, we made here the comparison. We had about 13 patients with accessory renal arteries which are not completely ablated. And the results we saw, you can see in the following slide. Patients with a complete renal denervation, here about 50 and 3, had a significant blood pressure reduction after these 6 months. In contrast to that, the ones with incomplete renal denervation didn't show this effect. And I think if you look at the right side, where you can see the blood pressure changes from baseline to the 6-month follow-up period, for each patient, you can see that there's a significant difference. Patients with a complete RDN had initial blood pressures of about 173 millimeters of mercury and decreased, in most cases, to about 155 millimeters of mercury in systolic office blood pressure measurement. Patients with accessory renal arteries, which were not completely ablated, didn't have this effect and remained on their blood pressure levels compared to baseline of about 171, 171 millimeters of mercury. So in conclusion, we can say that accessory renal arteries are a common phenomenon in patients with resistant hypertension and are often detected in the RDN screening. The problem is that accessory renal arteries, such as concomitant main branches and pole arteries, are often too small to be accessible for the renal denervation procedure. So this is the first study that points out a bit that you have to do the renal denervation procedure completely. If it's possible because of the anatomy of accessory renal artery, you will be successful in this treatment option. But if you have small accessory renal arteries and cannot perform RDN completely, you will have no success in a blood pressure lowering effect after 6 months. I thank you for your invitation and would like to close my presentation.
Ladies and gentlemen, any questions from the press here? As you all know, renal denervation was something that really hit the rocks a few years ago, and we thought this is going to solve everything for us. And then it suddenly stranded, and we thought this was one dream and gone. And now suddenly you are reviving our hopes.
Yes, it's the HTN3 trial.
Yeah, I think there is hope for renal denervation anyhow.
Yeah.
Okay, if you would look ahead 5 years in time, where do you think we stand with this development?
I think I hope it's a good option for these kind of patients. Even if we have the results from the HTN3 trial, which was kind of a bomb this year. But I think the most important thing is to screen carefully and to select carefully for patients who really benefit from this procedure. I think this is the most important thing, and if we stick to that, we will see where we are in 5 years.
Questions? A gentleman from Russia, please.
Well, just wanted to ask, how do you measure the degree of sympathetic denervation? Do you have any mean of measurement of sympathetic activity, or it's just by blood pressure monitoring?
Yeah, this is one problem to this procedure. During the procedure, you are not able to measure the sympathetic nerve activities. There are some papers who measured it with a muscular nerve activity or with a catecholamine concentration in the renal artery, such as a correlation to the sympathetic nerve system, but you can't measure it directly, neither with this procedure, neither with any other.
So don't you mind that there might be placebo effect with this procedure then? Placebo effect? Did you have sham surgery to compare?
No, we have no surgery.
Marlene Busco from theheart.org. My question is very similar. How do you know that you've successfully performed the renal denervation?
During the procedure and during the first days or weeks, you don't have any point if you are successful or not. That's the problem of this procedure. There are data that shows that if the impedance, you can measure the impedance during the ablation process, and if the impedance decreases rapidly, so you will have destroyed the nerve system. But we haven't got any data that show us we are successful or not successful during the procedure. We can just measure the blood pressures after a period of time and hope that the patients stick to their medication, because we can just take the comparison if the patients stay on their medication levels and have no changes there, and this is a problem. This is an absolute problem.
Just to put it in the position.
Yeah.
How many?
It was about 19.3%.
90.3%.
And this is 1/5. It's not so rare.
You have general hypertension, yes.
Yeah.
Hi, Damien from Côté du Médecin. What are the means to evaluate exactly the accessibility of the renal nerves?
In the former studies, we have the simplicity trials. There was always the rule that the renal arteries have to be longer than 20 millimeters and have got a diameter of more than 4 millimeters. We take some measurements out of the 3D MRI reconstruction we did in our hospital. What I have to say is that there is no millimeter that can tell you you get access to the renal artery or not. You just have to try it. If the renal artery is bigger than the catheter system, which is about, I think, 2.5 millimeters, you should try to set the ablation electrode at the wall. And if you get a good access with that, then you can perform the ablation.
One question, Jan?
Anita Greilhuber from Cardio News Austria. Knowing these results, what would you offer to a patient with resistant hypertension and accessory renal arteries?
I think this depends on the kind of concomitant arteries or accessory renal arteries we have. I would perform a 3D MRI reconstruction to take a look how these renal arteries are configured. If it's possible to get access with the catheter system, and if secondary causes for hypertension and non-adherence to drugs have been excluded, then I would try to perform this procedure, but just in this case.
But what? Yes?
You cannot access this.
Then I wouldn't perform this procedure. Then it's not technical, not possible.
And what would you offer then this patient?
This is a difficult question we have to answer.
Medication.
Yeah. You just can try to change our medication levels. We haven't got so many options to treat these patients. This was the problem since 2009, since renal denervation was invented. There were some data from 1930 where somebody took out the whole sympathetic nerve system. So they had a blood pressure lowering effect, but all other effects were even not so good. So we have no more option left right now.
What does it cost?
Depends.
That's a very.
No, it's
Can I afford it?
It's you don't have to afford it if you have got how can I say is you don't have to pay it. It's about 4,000 euros. This process.
4,000 euros. Okay.
Yeah.
Thank you very much, Heinz. As our ESC spokesman, is there hope for renal denervation now? What do you think?
Well, you have given us a bit of hope that was destroyed in March at the ACC, and predictions are difficult. But I think you said the important thing. If you make a better screening, then there is probably a better chance. So my summary was a better screening that in history was made. Then I think you have a more precise indication for the procedure. And I think, to answer your question, yes, there is a future.
Okay, fine.